Hi, my name is Stephen Ludwig. I'm going to be talking about the prevention of complications in cervical spine surgery. There's no question that there's an increased number of cervical spine surgeries that are occurring in the United States, and there's clearly an upward trend in the mean age of the patients that are undergoing those surgical procedures. We know that patients, when they reach the age of 75 and have cervical spine surgery, are at a higher risk of developing a complication or even dying. There's also an increased risk of having a perioperative complication with increased OR times, ASA classifications, and partially dependent or totally dependent patients. And we know there's clearly a difference between a patient's chronologic age and their physiologic frailty. So you need to consider these when making a decision to operate on a patient. We all know that if you do surgery, complications will occur, and selection of the appropriate candidate and patient is paramount to having a successful outcome. Correlating a patient's history, physical examination, plain and advanced imaging studies, determining your surgical goal, optimizing the patient medically, and having an informed consent discussion with the patient is key. Selecting the appropriate approach is usually where your decision-making begins. It's typically determined by the location of the pathology, the alignment of the cervical spine, and the number of levels that are involved. One of the take-home points is that an absolute contraindication to going from a posterior directed approach is a kyphotic spine, which does not allow the spinal cord to migrate posteriorly when decompressed. There's a plethora type of complication beyond the scope of this discussion today, but what we're going to talk about is the most common complications that I believe we all will see on a day-to-day basis. It all starts with intubation and anesthesia. Maintaining an elevated mean arterial blood pressure in the setting of myelopathy and severe cord compression or in a deformity, trauma, tumor reconstruction is paramount to their spinal cord health. Doing an awake fiber optic intubation or a glide scope in patients with a difficult airway, avoiding hyperextension in an unstable cervical spine can also reduce the risk of having an iatrogenic spinal cord problem. What about postoperative acute airway compromise? This is an extremely rare event. We know the risk factors are in multi-level procedures, people that have prolonged surgical procedures greater than 5 hours, revision procedures, patients that are losing blood, they may be obese, sleep apnea, or COPD, but early detection, having a team awareness, maintaining postoperative intubation, and doing a cuff check postoperatively to see if you can extubate the patient. And beware of BMP. If you use it in an off-label indication, can really mitigate this postoperative airway problem. Positioning problems can exist either anteriorly or posteriorly. Posterior directed approaches are usually more complex in positioning. I do it the same way every time. I use an OSI table. I position the patient supine. I use a Mayfield cervical management system. I pay careful attention to their sagittal positioning, especially after I flip. I check their alignment with fluoroscopy. I make sure their occiput is above the level of their thoracic apex. And I check pre-op flips or pre-flip potentials as well as post-flip potentials to make sure there's no change. The most common complication with anterior-based surgery is dysphagia. You need to set the expectations with the patients and reassure them that most will resolve over time and will rarely go on for more than 12 weeks. I think in the face of multi-level corpectomies, you have to make sure that you're ruling out a mechanical failure of your construct that can be an iatrogenic cause of an airway problem. We know that there's a local effect of using steroid applications, and that can be helpful in mitigating postoperative dysphagia. Other anterior soft tissue related problems include recurrent laryngeal nerve problems. These are probably more common than we think. It's usually transient with hoarseness and dysphonia, maybe associated with dysphagia. And patients that have a higher cervical approach, be careful of the superior laryngeal nerve injuries. Typically, you can prevent this if you pay attention to the time and the duration of retraction, and the pressure of the retraction can be reduced with meticulous soft tissue dissection. And I think in complex revision situations, bringing in an ENT evaluation to help you with the approach can be dramatically helpful in getting a successful outcome. In primary cases, there's probably no association between the side of the approach and the incidence of recurrent laryngeal nerve injury. What about an esophageal injury? This is another rare but potentially devastating injury. I think protecting the esophagus by putting your retractors beneath the level of the longus colli muscles, putting an NG tube so you can palpate it and palpate the position of the esophagus I think can help reduce the risk of having an esophageal injury. I think in anybody showing up to your office after an anterior cervical approach that has a wound infection, you got to rule out an esophageal injury. I typically would use a half-strength hydrogen peroxide test, about 30 cc's, placed down the NG tube to see if it foams up inside the wound. And that is a very sensitive way of looking for an occult esophageal injury. If you find out that you have injured the esophagus at the time of your procedure, I don't hesitate in getting ENT involved for a direct repair or sternocleidomastoid flap. You got to put the esophagus to rest, antibiotics, either a PEG tube or an NG tube, but you need functional closure of that perforation to prevent further infection spread. What about another rare but potentially devastating complication? Spinal cord injury. The risk, you can reassure your patients, is probably less than 1%, but careful, meticulous control of the bleeding, appropriate use of the right surgical tool, adequate visualization, and slow down at the appropriate point during the decompressive procedure can really reduce the risk of having a spinal cord injury. At the other end of the spectrum, avoiding inadequate decompression can be done if you carefully correlate your preoperative imaging studies to what you find during your preoperative decompression. That could potentially avoid that problem from occurring. Probably the most common neurologic complication that we see in cervical spine surgery is the C5 nerve root palsy. It can be a devastating problem, but hopefully it portends a good outcome. It seems to be more common with posterior directed laminectomy and fusion procedures with an overall incidence of 6%, but a range from 0 to 30% depending upon which articles you read. The risk factors are not only a posterior directed approach, but patients that have OPLL and even males compared to females. Some of the ways to prevent it, you may want to consider doing a prophylactic foraminotomy. Being careful with looking at the width of your laminectomy is really important because it may allow for more migration of the cord, which may increase your risk of palsy. Some may think that if you leave the C5 lamina, it may reduce some of the excursion of the spinal cord, thus reducing the risk of having that palsy. Avoiding taping on the shoulder and keeping your arms elevated postoperatively to reduce the tension on the brachial plexus may also be somewhat helpful. Another rare but potentially devastating problem is a vertebral artery injury. It's probably less than 1%, more commonly seen with anterior corpectomies or posterior instrumentation, especially in the upper craniocervical region. Some of the mechanisms of injury and the ways to prevent them, well, when you're doing your corpectomy, you want to stay within the confines of the uncus. That width should be no more than about 17 millimeters. If you lose your site of orientation, bring fluoro in to regain your understanding of the local anatomy. You got to really scrutinize your plain and advanced imaging studies to look for unrecognized vertebral artery injuries, the tortuous vertebral artery, or any other anomalies. When using a burr, especially during the lateral aspects of your decompression, especially in a corpectomy, I typically use a diamond burr. I think this is less damaging to the soft tissues. And when you're doing posterior directed instrumentation and approaches, when you're doing pedicle screws at C2 or C7, I think looking at, once again, your advanced imaging studies, understanding the position of the foramen transversarium, your pedicle morphology. I do a direct laminoforaminotomy technique and palpation of the pedicle, and when in doubt, bring fluoro in to guide you. When you're dissecting in the craniocervical junction, be careful along the posterior range of C1. If you stray lateral more than about 12 millimeters, or during the superior aspect of the C1 ring, more than about 8 to 9 millimeters, it puts the vertebral artery at risk. And if you get into it, you got to stop, notify anesthesia, get blood, and get some help. Direct repair is usually preferable, but it may not be feasible. You need to understand that if you manage it with a hemostatic agent alone and tamponade effect, you're going to have a complication about 45% of the time. And if you decide to ligate it, especially if it's the dominant side, there can be a risk of having a neurologic problem, including a stroke, nerve root injury, or a cranial nerve problem. Lateral mass screw fixation for posterior fixation has been shown to be very safe and effective. Getting familiarized with the different techniques, understanding the mechanics and the techniques, and scrutinizing your preoperative advanced imaging studies can avoid having a potential mechanical complication. What about anterior-related hardware complications? We do know that, especially in multi-level corpectomies, 2 or even 3 levels, there are supraphysiologic loads, especially when plating, that can cause pistoning of the graft into the end plate and can cause end plate failure, collapse, and graft migration and hardware failure. I think in order to avoid these problems, you need to maintain the structural integrity of the end plate. I typically create a lip along the docking vertebral body to prevent against posterior migration of my graft or cage. I usually am very weary of using Caspar pins, especially in osteoporotic spine. I've plowed them out and pulled them out, so you got to be very careful. I'll put cervical tongs on to mitigate that risk. Once again, pay attention to the width of the corpectomy, stay within the field goal of the uncovertebral joint, and I remove all my distraction prior to anterior plating. I think another way of choosing or avoiding complications is choosing the appropriate approach. For somebody that doesn't have a cervical deformity, that has a single level vertebrectomy, I typically will do it from an anterior related approach. If you have a 2 or 3 level problem, I typically will go anterior and posteriorly. Somebody that has a kyphotic deformity, osteoporotic movement disorder, trauma, tumor, infection, I'll consider going front and back. And in those cases where you're doing multi-level corpectomies, I will typically use a kick plate or a junctional plate to prevent against the graft from migrating during a multi-level corpectomy exposure. We all do multi-level ACDFs and know that as the number of levels that need to be fused, the number or the incidence of pseudoarthrosis rises. We also should understand that nicotine, nonsteroidals, the host status can play a role in the risk of pseudoarthrosis. I usually quote patients when I use allograft bone, which is my personal choice, about a 4% risk per level. We do know that not all pseudoarthrosis patients are doing well. About 30% of them may have unsatisfactory results. Postoperative wound infections are more common posteriorly. Sometimes you need to have a high index of suspicion. There are uncontrollable and controllable factors, including somebody that's malnourished, smoking. I usually like to get their A1C under control, less than 7. And to reduce the risk of bleeding, I typically will use TXA that has been shown to reduce this risk. I also do a chlorhexidine scrub, upiricin, betadine soak for posterior, and local vancomycin powder to reduce the risk of having an infection. Usually in high-risk patients, we may use some incisional vacs that can reduce the local wound dehiscence, and we use them for about a week. So in conclusion, complication rates are typically low, but need to be addressed because they can be catastrophic. Prepare your patients for the problems that may exist. A more informed patient is more understanding. Meticulous attention to detail can make the difference. Preoperative planning, communication with anesthesia, a knowledge of the anatomy, spinal cord monitoring, and understanding of the mechanics is important. Choose your patients wisely, know the diagnosis, understand the natural history, and study your results and change accordingly when you have to. Thank you so much for your time.